Good evening, everyone. Thank you for joining us for the second session of our START assessment series that organized by the British Sudanese Association of the Pediatric and Child Health. My name is Ayat, and I will be moderating this event. Before we begin, just a few quick notes. This session is recorded and it will be in the British Sudanese Association of the Pediatric and Child Health YouTube channel if you want to go back to it. And if you have any question during the session, please feel free to put them down on the chat and I will share them at the end of the session, or you can unmute yourself at the end of the session and share your question. Let's start. I'm delighted to introduce Dr. Hani Gowai, the president of the British Sudanese Association of the Pediatric and Child Health. Dr. Gowai graduated from University of Jazeera in Sudan, completed his training at Sheffield Children NHS Trust, and is now a respiratory pediatric consultant at Royal Aberdeen Children's Hospital. Dr. Gowai is not only a distinguished clinician, but also a passionate for supporting international medical graduate IMG's doctor in establishing their career within the NHS. As a transformative leader, he has made a significant contribution to improving the training and development of the pediatric trainee, leaving a lasting positive impact on the field. We are especially grateful to Dr. Gowai for taking the time to join us this evening to share his insight and experience during our second session on critical appraisal and incidents reporting as a part of the STAR series. Please join me in welcoming Dr. Hani Gowai, a true inspiration and leadership. Welcome, Dr. Hani Gowai.
Thank you, Ayat. Is my voice well heard?
Yes, we can hear you very well now.
Okay. Thank you for the nice introduction. I barely recognize myself while you were talking about me. I can see from the attendees that we have a number of non-Arabic language speakers. So I'm going to restrict myself to English only. Okay, so START is kind of the exit exam, of course. You know, it's other specialties have exit exams. In pediatrics, we don't have an exit exam, and this is considered the equivalent to the exit exam, although it's not an exam. It's not a test, as they keep repeating and they keep saying it's an assessment, it's not an exam, there's no pass or fail, but there are recommendations and notes about your performance and indicators that they will be commenting on. They expect you to take the assessment at the level of day one consultant, and based on that, they will either, you know, give you for every station, you will be assessed on a number of things, and for every station, you will be given either that you are performing above expectation, or you are performing at the expected level, or there is a development is required, or there is serious concern. It's very, very, very unlikely that you will get a serious concern unless you do really something silly, or you know, you have just not been during this training doing anything, you know. But it's very, very unlikely for you to get a serious concern. I think only a handful colleagues got it, I think, previously. Less than a handful, actually. But it's very likely that you will get a number of stations as need development. That's absolutely fine as long as you can work on it. So, you know, you can even get all the stations as need development. That does not mean anything. It will not stop you from having your CCT. You just, it will just increase the amount of work that you need to do in order to get your outcome 6, which is completed training successfully. Because you'll have to work on these PDPs. Okay, so today I am going to talk about two things quickly. One is a critical appraisal, which by itself, we can be talking about it for like 3 hours at least, if we go into it deeply. And the other thing is, um, I'll touch a little bit on the complaint and the complaint procedure if you get one. Okay, let's move to the first session. Oops, first slide. Is it moving? Is it moving?
No, yes, it is moving.
The slides are moving.
Yeah, it is moving now.
Okay. Thanks. So the critical appraisal, yeah, exactly. When you are presented with a paper, it looks like that. Very complex picture of numbers and statistics and results and things that you need to make sense of each. Um, we are very lucky now that you get sent the paper a week at least before the assessment. Previously you attend face to face and you get given the paper on the day of the assessment. You get given 40 minutes to read the paper and appraise it. And so now you should consider yourself really, really lucky that you will have 7 days, to look into the paper and prepare it. So there is no excuse for you to get any issues with the critical appraisal because you should digest this paper in and out in 7 days. Okay. So what should I be looking for when they give me this paper? Usually the paper is associated with a clinical problem. So usually there will be a clinical case presented. So for example, a registrar in the unit was preparing a patient for an MRI and decided to give the patient chloral hydrate or midazolam or something that is not usually used in the hospital for non-procedural sedation. And so because they read a paper about non-procedural sedation using chloral hydrate or midazolam or whatever medication they decide on, and they spoke to their consultant and said, you know what, can we use this for our patient? And then they present you with the paper and asking you to critically appraise it and decide whether it's good for use or not. So the first thing you need to decide on is the paper relevant? And when we say relevant, that means relevant to your practice. Are the results valid? I'm going to talk about each one of these four domains in details in the next coming slides. So is the paper relevant? Are the results valid? And if the results are not valid, you cannot move to the next one. So you have to get one by one. If it is not relevant, that's it. You've put a full stop and say, this is not relevant to pediatrics and there's no point of going into it. And that can be the end of the station, but it will not happen. Are the results valid? What are these results? If the results are valid, then we look into the results and decide whether these results are good to go for. And then the generalizability and applicability to our practice, which is the last stage of any evidence base that we are presented with, because not every evidence base is practical and not every evidence base can be applied to our daily practice. Okay. So the question about is it relevant? You need to read the scenario and decide about that. You have to compare it to your own practice. Do you actually request MRI for kids that need to be put to sleep before having the procedure? Absolutely yes. Then that is relevant to your practice. Do you struggle with putting kids to sleep? You give them the medication, they don't sleep, the procedure is canceled, the MRI people are angry because the slot is being delayed. All these things we have been through, and every one of us have been through one of these. So definitely that one is relevant. And this is the first statement you need to say to your assessor during the station, that the first thing I would like to comment on is that this problem is something that I face every day in my practice. Is something that we do every day. We request echocardiography, we request MRI, we request all these things, non-procedural um, investigations or processes that we need to put kids to sleep with. And so this is definitely something I would like to look into for more details. That's the first thing you need to comment on when you are talking to your assessor in that station. And then you move on to the next. The question about are the results valid? This is the bulk of your discussion with the assessor. So I'll go back a few slides. So, the last column at the bottom, the generalizability and applicability to practice, that's going to be the shortest discussion ever you will have during that station. Is it relevant? Is going to be very short as well. The bulk of the discussion is going to be at the bits of, are the results valid and what are these results? Okay. So are the results valid? And here comes the real critical appraisal. And here you need to use your tools. And as the paper is presented to you 7 days already in advance, you've got no excuse other than to go and use the one of the tools that is available for people, like the CEBM or CBM, or the CASP tools for appraising this paper. So to decide whether the results are valid or not, you need to look into whether the investigators and whoever took the research or whoever took the study did it in the right way that a research should be done. Okay? So in critical appraisal station and start assessment, it's very likely that you will get either a systematic review or a meta-analysis or an RCT. These are the common ones that you will get. Most likely, systematic reviews are the commonest to appear in start assessment. It's very unlikely to get an observational study or a case review or a case series or anything like that, because we all know that these are lower down in the pyramid of quality. So the highest is meta-analysis, and then the systematic reviews, and then the RCTs, and then the cohort studies, and then everything comes down below that. So it's very unlikely that you'll be presented with a low quality paper. It's very likely that you'll be presented with a systematic review. So these are the ones you need to practice more, and you need to go and make sure that you are at least getting the grips of the main bits of it. So we're looking at the paper. Number one, do not read every bit of the paper, but because this was used to be said, because you were given the paper during the day of the exam, a day of the test, day of the assessment. But now you've got 7 days. I don't think it's bad to read the whole paper because you have enough time. So read the paper. Read about the population, because with every study there is the PICO four elements, which is population or intervention, what is it, comparison, and outcome. So these are the things you need to read about to decide whether the results are valid or not. The population will be decided if it's a systematic review. Let's say they are talking about kids between 0 and 18-year-old who are having non-procedural sedation. This is your population now. The intervention is the non-procedural sedation, but they need to be very specific here. They need to decide what procedural sedation they are talking about, because you can use chloral hydrate, you can use midazolam, you can use other types of medications. Some people use promethazine. I've seen some units use very different medications, for procedural sedation, non-procedural sedation. And so they need to be specific at what non-procedural sedation they want. Or they can also decide that we want to include all the studies that have non-procedural sedation, regardless of what medication is being used. That's just something you can keep on in your mind when you come and comment on the papers later on. So if it's a systematic review, make sure the population they are choosing is very specific, very, very, very well decided, age range, if they want to do only males, if they want to do only females, if they only want to do trisomy 21 patients, if they only want to do trisomy 21 patients who have hypothyroidism. So, population has to be decided. Intervention, as we said, outcomes. And here comes the important bit. No study will be a study without an outcome measurement, because that's what you're going to measure everything again is at the end. And that's what's going to decide whether your intervention is working or not, your outcome. And then the outcome can be a successful procedure. So a patient went in, had their MRI, and came out without waking up in the middle of the procedure, and that is considered success. Or is it, if the patient slept, went in, and woke up in the middle of the procedure, that will be considered also success because the medication actually worked, but someone whatever, dropped something and the patient woke up in the middle of the procedure. So that was not the fault of the medication or the fault of something else. Okay. And then the secondary outcomes as well. Okay. Now you need to look into also the selection of the studies. How did they select the studies to include in that systematic review? And this is important because this is the bit that can be decisive about whether this paper is valid or not. Did they do enough search? Did they search all the databases that we know about? So that will all be written within the study, their methodology. This bit is about the methodology. You will go into the methodology and then you'll find all these boxes around there. So the search, we searched the database, we searched Embase, what was the other one? My mind has got a block completely now. So, but the Embase, and other ones that are very well known, they searched since 1948 until now. They looked into English language papers only, or did they look into other languages as well? Did they look into Spanish? Did they look into French? Did they look into Chinese? We know Chinese have got lots of papers out there, but because they are not in English, no one usually looks at them. Did they look at papers that are not yet published, so unpublished papers? Did they contact researchers asking for full papers if they've seen an abstract or something? Did they look into conference abstracts as well? Did they contact the publishers asking for a full script of the whole thing? So all these details will be mentioned and will decide on whether the quality of this systematic review is good enough to go for or not. The bias is a tricky one we are not used to, but the authors themselves will mention how they actually measure the bias. There are some bias measurement tools. One of them is the known one, the Cochrane one, but there are other ones. I think there's one called Newcastle Ottawa or Ottawa Newcastle bias tool or something like this. So there are different tools for measurement of bias. You need to understand which one they used and how they used it. And when they selected the studies also, the bias here comes also. When they selected the studies, usually there are 2 or 3 researchers together, but did they do their selection of papers independently? So each one of them looked at 500 papers and decided which papers need to be included without talking to others, without influencing others. And this will make it more robust and more reliable and more believable. The quality of the studies as well, and this is when you have to go into each of the studies of themselves. But if you are presented with a systematic review, that's probably not easy for you as an appraiser to do that, but those who selected the papers will mention something about the quality of studies they selected. Because if the quality of individual studies is poor, then maybe the quality of the whole systematic review is also poor. The quality of the study is decided by what? If all the studies included like 30 studies, all included 6 patients in each, this is an absolute rubbish. But if the papers included like 300 patients, 400 patients, thousands of patients, the number of subjects included in a study is significant enough to draw some statistical, numbers and some statistical significance, then that is something you need to consider as possible good quality study, although other stuff might also influence the quality of the study. I just mentioned only one, like the number of subjects in each study. But the bias, the way they searched about it, the way they excluded the studies and all that, they need to mention very clearly why they excluded those studies, how they excluded them, and the reasons for exclusion of every study they excluded. Excluded this because of that, excluded this because of that. If there is no mention of that, then that is not a good quality systematic review. Okay, I think I'm going a little bit fast. Please feel free to stop me or write in the chat or anything in the middle of the session. And if you wanted to ask a question or anything, can't wait to the end, I am happy to be stopped. The subgroup analysis. Yes?
Yeah, there is a question from Muhammad Osman. He asked, could we start with the PICO question for the critical appraisal?
Yes, you can actually, but well, what you're doing actually is, I'll tell you how the station works. So you move into the station, the clock start ticking, and the assessor asks you, Muhammad or Ayat, you were given this paper and so forth, and you have read it already. Can you tell me about what you got from this paper so far? And then you start talking about, okay, before I start talking about the paper itself, I would like to mention that this paper is very relevant to my practice, because the clinical problem mentioned is something that I face every day in my practice. And I think the question asked is really valid and something that we can look into. Okay, I looked into this study, and I think that the first question I ask myself is actually, is the study valid or not? And to answer this question, I had to look into a few bits to decide about this. And one of the things I wanted to look into is how they selected their population, their intervention and everything. When I did all this, I had the PICO acronym in my head, which is, the population, the intervention, the comparison, and the outcome in mind. And looking into these details, I can tell you the following, and then you go into it. So, Muhammad, you can mention PICO, um, but eventually mentioning PICO will not save your life. What will save you is understanding what is behind PICO and how you go into each one of these letters. Um, the subgroup analysis is systematic reviews will collate papers, big papers, and then bring them together. Not all these papers have the same cohort of patients. Not all these papers maybe use the same thing. As we mentioned, some papers may use midazolam. If we're talking about that non-procedural sedation, some papers might be using chloride hydrate, and some papers might be using something else. So, um, did they do a subgroup analysis? So they collected all. So let's say they said they had 30 papers in their systematic review. 10 of them had chloride hydrate, and 10 had midazolam, and 10 had something else. Did they do a subgroup analysis for the midazolam only papers to see whether that was actually different to the chloride hydrate ones or not? So that is the subgroup analysis that I was talking about. Or suddenly they found out actually, did they do a subgroup analysis for patients who had what is it, neurological problems? Because we know these can affect your sleep, and can affect your behavior with these sleep medications. So did they do these things or not? And if not, it's, they don't have to do it, but it's good if you comment on that and say they did this, they did not do this, and this is my opinion on this. And this is how the assessor will be looking at you. They are assessing your understanding of the appraisal principles behind. So when you look at the CAST tool, there are lots of questions in the CAST tool, but what does every question mean? If you don't know why you are asking the question and what's behind the question, then there is something you are missing here. Okay, just a sec. Sorry for that. Um, I'm just going to move to the next slide. Is it moving? Is it moving?
Yeah, it is moving.
Yeah. So these are the things we spoke about in the previous. I'm just here putting them for more details. Is the population clearly defined? Do they have age limits? Other characteristics, the intervention, is it very well defined intervention? We are going to give chloral hydrate 30 milligram per kilogram at the beginning, half an hour before the procedure. All these kind of intervention details, are they really defined or not? Is the intervention very wide, not very specific? This is exactly what we were talking about, in terms of having different medications and different things. The outcomes need to be very clearly defined, and exactly what are we talking about, primary, secondary, and what are we expecting at the end of the intervention, that the patient will have the whole procedure done successfully without waking up in the middle of the procedure. That is considered outcome, primary outcome. The selection of the studies, the type of the studies they included, are they all homogeneous? Exactly what we're talking about again. This is just putting it into details now. Um, uh, Homogeneous is the opposite to heterogeneous, and the heterogeneity is one of the things that will cause the study quality to be a little bit low, because if you include different things, it's very difficult to draw conclusions and generalizability if the study subjects and the selection of the things is not very homogeneous. And this is why the subgroup analysis becomes important here. Okay, so the search. This is what we spoke about again. I just put it here into more details. What databases they searched, did they use personal contacts, unpublished papers, used other languages, who did the selection, and the exclusions clearly explained. The bias, again, we spoke about this, what tools were used. You know, there are different tools, as we said. The common one is the Cochrane bias tool, but there are other tools around. Everything about this will be mentioned in the paper. They used these, we use this and this to exclude bias. And so you just have to mention it. The quality of the studies, have they assessed the quality of each study? The, the, um, the investigators who are doing the systematic review or the meta-analysis must look into the quality of each study before including it. You don't include just every study because it fulfills, you know, your population criteria or something like that. No. As I said, you know, a study that only has 2 patients that has got no quality in it. So there's no point in adding it into your systematic review. How did they assess the quality? Again, there are few indicators about assessing the quality. You need to look into the directness, you know, the precision, the consistency of the study. You don't have to go into details about this. As you can imagine, this station is very limited with time. You're not going to talk about it for 20 minutes. You've got very limited time. So you have to be quick in your talking. I can tell you the assessor will not stop you in the middle of the talk unless you pause, and you pause for a while, asking him to intervene, you know, with a prompt or with a question or with anything. They will let you just keep going. So that is also a good thing. Subgroups where they analyzed. And now the next section. So we spoke about, is the study relevant to your practice? We answered that question. Are the results valid? You said yes, because you looked into everything, you know, population, quality, selection, research, and all that. And now you are going to delve into the next section, which is what are those results actually? And now this is the bit you need to mention, you know, if there are some numbers to be mentioned, if there are percentages, you know, if there are, you know, specificities, what is it, hazard ratio, relative risk, all these things. If you think they are relevant to the study, that you need, this is the time to mention it. So do not try to go around these things. Just go directly and say the results in numbers straight, say this and this and that. The results of this study, they included 100 studies, and the results showed that actually midazolam is not a good medication for this and this and that, because this is what happened. Was the interventions useful? No or yes, but why again? You cannot just answer the question and stop. You have to go into the explanation behind why is the intervention useful, was the intervention useful or not, and why not. And then you have to give your own opinion as well. Don't forget, you are reading the researcher's opinion, but the assessors are expecting you to have your own opinion. The researchers have done their bit. They produced the paper, they published it. It's on you to decide whether this paper is good to be used on your patients. And you cannot do that without criticizing it like this. Statistical versus clinical significance. This is a concept that you have to grasp and you need to understand very clearly. Not a lot of studies do not have statistical significance. That means that the researchers did not find a difference between midazolam and chloral hydrate in whatever, but the clinical significance was very relevant because the majority of patients with midazolam had more side effects, for example. That is a clinical significant thing for you. So if they are equal, then you are likely to use chloral hydrate to avoid the side effects coming from midazolam. That is a clinical significant thing that you found in the study. So not all the statistical problems with the study are actually bad, because sometimes they draw other stuff with them. So again, by reading the study, because you have 7 days to read it, there is no excuse to miss that, by the way. And I'm sure you're going to pick on it. Okay. The last question, which is going to be very short to answer during the assessment, is the generalizability and the applicability of the study. And that is very straightforward. You have read the study, you have criticized it, you know the results. Can you take this paper tomorrow to the anesthetic department and say, I'm going to use chlorohydrate from now on, and we're going to produce our own guidelines for this hospital from now on for MRI for kids between 1 and 10 or whatever the study was looking for? That is a question. You have to be very clear. You have to be very direct. There's no problem at all with saying, I can't see that this study is applicable for my practice at the moment for the reasons one, two, three. It is your opinion. It's nobody else's opinion. It's yours. And you have to say why you are doing it, why you are not doing it. Whether you chose to use the paper or whether you chose not to use the paper as an evidence, why and how and all that kind of thing. So by the time you reach this point, you and the assessor are already on the same page, because you already have explored lots of the details and you are just preparing someone for the final. You take them gradually, step by step. This study did this, showed this, it showed this and that. I looked at this and that. I looked at this and that. And for all these reasons together, I'm not going to use this paper for my patients. And it cannot be applicable for the current setting for the following reasons: one, two, three, four. And this is the way to do it. It's a little bit easier, I'll have to say, for systematic reviews, or maybe that's my personal opinion. But systematic reviews are good to have in start assessment, because usually they are straightforward. The statistical things behind them are not very bad. For preparing for start, I had to go to YouTube to understand few things about few concepts. Um, and I will advise you to go also and read about them, because you might get a meta-analysis, not a systematic review. So you need to understand, like, for example, the forest plot. If you don't know what forest plot is or what that diamond mean, if the diamond is big, if the diamond is on the left, if the diamond is on the right, you need to go to the YouTube. YouTube has got everything, by the way. They explain you everything in very simple language. So I personally used it before my session. Um, what's next? Okay, so that's all about critical appraisal. As you are going through the station, the assessor might want to intervene, by the way, and might want to have their own opinion and say things, because they already read the paper, by the way, and they have their own opinion. That's absolutely fine. The stations in start, not just the critical appraisal, all of them are kind of a chat between you and the assessor. Do not take it as an exam. I have never felt in an exam during that station. And don't forget, you are not a registrar. While you are answering all these questions, you are day one consultant already. You have completed your training and they expect you to answer that question based on that level. So forget about your registrar's mind subconscious thing, and get it away and get that out. Um, the assessor was smiling the whole station. I was smiling back, you know. It's just one for one. Um, I put a sticker near my camera here at the top of my laptop, and I wrote on it, keep smiling and keep looking at the camera, just to remind myself, because sometimes with virtual meetings, we tend to look into the ceiling and we tend to look into sideways, and we all did this. But now they expect you to be eye to eye contact, and all these things virtually is not easy to maintain. So just remind yourself of these little cues, and remember, you're talking to someone who is your colleague, same level. Well, they're a little bit experienced more than you, but it's the same level. So there's nothing to be worried about. Happy to take questions now for critical appraisal or comments or anything. Either
Zero.
open your microphones or write in the chat. I can't see the chat, so you have to read it for
Yeah,
me.
there is no question in the chat. But if you have any question, please unmute yourself and feel free.
Our article was a retrospective cohort study, so it was slightly different than
Mm,
what you mentioned, but yeah.
mm. That's unusual. Yeah, that's unusual. The common ones are the meta-analysis, the systematic reviews, the RCTs, and then the cohort studies come next. So you got the list of the chances. But yeah, you just have to get prepared.
Yeah.
I mean, by now, you are already ST7, ST/ST8. So you have seen, attended, and presented lots of journal clubs, and you have seen different types of studies. So you probably understand, the basics at least of what these studies mean and what the difference is between this and that. So, you're not going to struggle. Um, yeah, you're not going to struggle much. And remember, previously this study was given, this station was, they used to give you the scenario on the day of the assessment and give you 40 minutes. Now you have 7 days.
Exactly.
So
You
you,
have no excuse not to do it.
absolutely, you cannot get anything other than meet expectation or above expectation. um you know what, I'll tell you something about my station. So the station I had is exactly the scenario I was talking about. It was about the non-procedural sedation. That's why I keep using it. And I actually wrote my discussion in a paper. I wrote my thoughts, what I'm going to talk to the assessor in a paper, and I put all these big, subheadings that I was talking about earlier on the side, and I put them just in colors and printed the paper, and I was putting it in front of me. I practiced it by myself few times, in front of the mirror or the camera or whatever, and then by the time the assessment day, I was more familiar with the text. So I just use the text, to glance down and just to remind myself that I forgot that point, or the next one is going to be this and that. And it was flowing nicely. And I got really nice feedback about it. The assessor said, yeah, they felt that I had good knowledge about evidence-based medicine and all that. Um, it's because I was talking about the statistical concepts and I'm trying to add a little bit of flavor, so he wouldn't think that you're just mentioning something and you don't know what it means. If you mention the relative risk, they need to feel that you understand what it means to say the relative risk, or what it means to say specificity or sensitivity. Um, is there anything in the chat?
Oh, also one thing I suggest, you go back to the patient at the end, because the assessor asked me what you are going to tell the mother. So we start with a scenario and end with a scenario. So
Oh,
but
yes.
yeah.
That's a nice touch from you, Muhammad. Yes. Yes, always go back to the scenario. If I have this patient, I don't think I will use this scenario for that and that. But yeah, maybe we need more studies. Maybe we need bigger numbers before we can draw some conclusions. You can conclude like that. The study is not bad, but based on the numbers they included, I don't think it's good enough to just use it for practice, and we need more. Okay.
Yeah. Saria, she shared in the chat about CASP, CASP tool that you can use in all the type of paper. Thank you so much, Saria. She put
Yes.
the link on the chat.
So the CASP tool have links to every type of paper, and you just download the list and go through the questions. And as again, I keep saying this, but really, really, you have a week. You can you can dive into this paper in and out in a week, and you will be memorizing it by word. Just a week is just too much.
I think we can move forward because there is no
Okay.
question.
Yes, for the sake of time as well. So, complaints, a big daunting thing, and nobody wants to be complained against, and you don't want to see a complaint against another colleague, but this is part of of the
ليه؟
profession. It comes with the package, it comes with the salary. Um, you are in a high risk profession, and so mistakes can happen, whether intended or not, and misconceptions and misperceptions will also happen, whether intended or not. What you mean, other people might understand something completely different, miscommunications. So yeah, complaints will happen. It's about how you deal with complaints once they happen. And uh, I don't think any trainee completed their training without at least having one complaint against them, either by a colleague or by a nurse or by a patient or a carer or whoever. It's just unusual. You will have this experience somehow. So, how do you deal with complaints? Okay, so complaints can be anything, can be verbal, can be written, can be by the phone, can be a casual conversation. Anyone can be going around and just say, your colleague did this, or someone did that, or someone did this. It can be against you, it can be made against you or against another colleague. If you are a consultant, as you are in the start scenario, it might be either against you as a consultant, or it might be against one of your trainees or a fellow or a non in a non-training post. It can be made against senior or junior members of the staff. The details of the complaint can be made against clinical or non-clinical details of the care that was provided by the trust or the hospital. Okay, so and it can be also in primary care, by the way, but we're not in primary care. It can be made by a parent, by a carer, by a colleague. It can be made by the janitor. It can be made by the housekeeper of the hospital because you were rude to them. So complaints can be anything, and anyone can file one, and it cannot be dismissed. It has to be responded to. Okay. Sometimes patients or carers wants to make a complaint. A patient or a carer want to make a complaint, and they need help with it. You can imagine NHS will help them make a complaint. Actually, sometimes you may advise parents to make a complaint. I have done it myself many times, not because I wanted them to complain against a colleague or someone, but because I wanted them to complain against a failure of the whole system, like a waiting time in A&E when everything is busy, like winter pressure and all these things, or complain, like a dirty room or something. So in England and Wales, I think it's called PALS, Patient Advice and Liaison Service. In Scotland, it's called PAS, Patient Advice and Support Service. I'm not sure about what it's called in Ireland, but I don't think it's different from these. So these are the two bodies that will help a carer, a parent, or a patient, if old enough, to make a complaint, and they can actually signpost them, to the right emails, to the right phone numbers. They can even help them write it. They can give them forms to fill. They can even all that. So that's absolutely perfect and absolutely fine with the system. Um, and then how to approach it. A complaint has already been made. Someone has written it and sent it to the hospital via the email that they were given by Pulse or PASS. The complaint is received. Usually it goes into the DATEX system, usually the same system, but in a different category. It has to be dealt with in accordance with the trust slash hospital guidelines slash protocols. So the team which receives the complaint or the DATEX, it's the same thing, by the way, and not a very different procedure. They need to acknowledge the receipt of the receipt of the complaint. There is usually a timeline that is defined in the hospital trust slash trust guidelines. Then they assign a responder to it, because whoever receives it from the governance team is usually non-clinical, and if it's a clinical problem, they cannot respond to it because it has got details about management, about medications, about things like that. So they assign a responder. That can be a nurse manager, a doctor, or someone else. And then investigations will happen to decide where was the fault, or what can be made better, and whether actually something went wrong, and whether there is something to be learned from all this story. The usual thing is that the acknowledging the receipt needs to happen within 2 to 3 days. So you need to email back or write back to the person who wrote the complaint and say, we acknowledge the receipt of your complaint. We will deal with it in accordance with our hospital guidelines. We will respond to you within 21 days. If there is going to be a delay in the response, we will contact you again to say all that. This is the timeline. And then it will be assigned to you if it was for something that you have been involved with or one of your trainees, and then you investigate it. Some complaints can be answered immediately on the spot. You just apologize, and that's it. That's all they needed. Apologize. We are sorry that this has happened. You have not been given the warm water for your milk or whatever. You apologize, and the nurse goes back and brings in the water bottle or whatever, and then that's it, done. But there's another one that has been done against someone who made a wrong diagnosis, and there were complications. There was an amputation of the leg, all these big things. They need to go and investigate first before they respond. How do you investigate? You are looking for facts and facts only. There are no emotions, there are no personal opinions, there is facts. And facts can only be drawn from records. That's the problem. That's why if you don't write it, it doesn't happen. It did not happen. And that's why they keep pressing you on, please write down. If you were called to see a patient, write down that you have seen them and that they're okay. Even that one line will save lots of time for you and other people later on if things go wrong. It happened to me before. I can tell you that one line I wrote made a big difference. You need to review case notes or for nursing or medical teams. Check PIU A&E records about waiting times. If the complaint was about waiting, then you have to go and ask about during that shift, how many patients were waiting when this patient arrived, what was the acuity of those patients, was there a big trauma, was the resus busy, were there enough doctors, enough nurses, staffing issues, logistics, was the system down, no one was able to see any x-ray on the system. Okay, that's not your fault, but it happened and it affected patient care and someone complained against it, so it has to be answered to. Interviews or statements, personal statements can be part of it. So you will be asked to produce a statement. Maybe some of us on this call have had done before. I personally did it. They ask you to write your personal statement about something that happened and that they are investigating, whether it's a serious incident or even a simple complaint. Interviews is the last bit, and it can be very stressful for people who are involved. And that's why, support and everything need to be in place for these people. So, probably you are all aware of this. Everyone knows about the fishbone skeleton, which is used to analyze problems and get to the roots of it. Usually the problem is at the head of the fish. And then you decide on the different labels. So the red labels that has got writings in them are changeable depending on the problem you have. So it says people, machines, methods, environment, measurement, materials. You can change them based on your own problem and your own environment. And then in each of these labels, you can put your primary cause, your secondary cause, and then it keeps going like that. So for a medication error, the big problem is that there was a medication error, but was the right drug prescribed in the right way? Was it dispensed right? Was it drawn the right dose by the nurse? Was it checked again by another nurse? Was it given in the right place? It was IM, but was it given IV? It was IV. Was it given subcutaneously? All these things. And the Swiss cheese model, when the mistake just starts from the beginning and then just keeps going and going and going and no one notices it until the end of the chain. So you can use the fishbone model if you are asked to investigate a complaint to get to the roots of the problem before you can write back your response. There is no writing back. There is no responding without knowing the roots of the problem, and you can only do that by investigating. Okay, how do you build up your response? You create a timeline of the events. Okay, that complaint came from a parent who was admitted with their child on a certain day at a certain time to a certain ward. These have to be in the timeline. Patient admitted at 10:30, at 10:45 was seen by the triage nurse, was found to have this, at 10:50 was given paracetamol, and so on, and it just keeps going. At 11:50 was moved to PIU, from PIU was moved to the ward after 3 hours, and then and so forth. So your timeline has to be like that, because the complaint that came from them will be within those timelines. And so if they said there was a delay in giving the antibiotic, then you can look into this timeline and identify exactly where was the gap and what was the problem, and then you go back and look into it. Identify issues in care, again, by looking back into your timeline and looking into the patient's complaint. Respond to all points raised in the complaint. You cannot ignore a single point raised by the parent or the carer or the complainant, regardless, about their issue. So everything, no matter how small that is, you just need to write about it, a response. Some stuff might not be relevant to you. So a parent was complaining about the dirty cubicle that they were put in. It's absolutely not your role as a doctor to go and clean cubicles. But to answer that, you need to go back to that nurse manager or whoever was managing that shift and ask them on the day of that event, what was the problem with cleaning the cubicles? And then respond back. Absolutely, you're going to offer the apology here, because dirtiness is not accepted regardless of what the reason is behind. Um, so you need to apologize about that without knowing, I think, even the reason behind it. But then you can explain to them that there was an issue with the staffing. This is not your fault. This is not, this shouldn't happen. And we are working to help, we're working to resolve it so far, yeah. And then how you respond after so it all starts here. You receive the complaint. You are assigned to investigate it. You go back, you look into the notes, you interview people, you ask people to write statements, you make your fishbone analysis model, you fill it up, you understand what's happening, you go and find the problem, and then you identify the issues. You start writing down, what are the problems raised by the parent or by the complainant, and then you start responding to them one by one, and then you start writing down the final response. Start with an apology, if appropriate. Sometimes people are just angry and want to complain against nothing. You don't have to apologize about something that wasn't a mistake. So this concept, we need to be very clear about it. If there was a mistake, we definitely apologize about it. If there was no mistake, you can apologize about the way they have felt, but not the mistake, because there wasn't a mistake from your own opinion. Because a mother will write, I'm very disappointed in the care you provided to my child on the day of so and so. And then I will start my response by, Dear Miss or Mrs. So, I'm very sorry that you have felt the way you felt, about our care and all that. And I'm going to respond to all your points in the following paragraphs. And then you go around and write down. You need to acknowledge their distress and disappointment if they have shown that in their letter or their complaint. It's better not to use staff names and only use job titles when you are responding, unless the complaint was against you and you are responding about yourself, then you can always mention names. But you have to mention the patient names, so if you are talking about Alice, you write Alice. If it's Alfred or Alfie or whatever, you just write their name in the response. Mention dates, times, places as necessary. Explain why things happened without trying to Don't make them feel like you are trying to, what is it called? Reason the mistakes that happened. No, mistakes happened. I'm just telling you that there was a delay because there was a system failure. We couldn't see the X-ray and it took a while to resolve that. That was a mistake from the system. We are sorry that this happened. But since then, we have put things in place to avoid this happening in future, this and this and this and that. So you know what? This is how you do it. So this is how you build your response. The apology, acknowledging their distress, try avoid names of staff, no blame for individuals. I did not put this here, but it's should be the biggest one. There's no blame for individuals. It's all about system failures, procedural failures, process failures. Admit mistakes, as I said, if there are none, mention the system issues, mention trust and individual learnings. Okay, there were mistakes made. We as an organization, we are learning from this. We have put in place an audit, and there is an investigator who is going to produce some recommendations at the end of the month. And then we will take this into account and then change the whole thing. Always offer a meeting either in the middle of the procedure of the responding to complaint to explain to them how everything is going, or at the end of the whole thing, offer them a meeting to come and discuss the results. I forgot to mention, once you receive the complaint, it's always good to call them and understand exactly. Sometimes writing isn't the best to explain what you want. And so you want to call them and say, we've received your complaint. We are going to respond to it. I'm just calling you to clarify a few things. I just wanted to know exactly what are your aims from the letter you sent to us. What are you trying to achieve? And then they can tell you the usual answers, I don't want this to happen to someone else, or I was very disappointed and my daughter has got a chronic illness and will keep coming to this hospital, and this I'm now doubting myself every time I come to hospital, so they'll tell you why they are doing the complaint. And so that's why it's always the meeting at the beginning, or the call at the beginning and the call at the end are important. Once you do the complaint, once you make the final response, usually you don't send it yourself. I'm not sure about other hospitals, but the hospital I'm working in now, I don't send the response myself. I send it to the governance team or the management team. They look at it, they look at the terminology, they look at the response itself. They can adjust or suggest some additions or changes or omissions. They look into the legal implications of what I have written in my response, and then they decide whether it's good to send or not. And if they are happy, if it's just a simple complaint, that's fine. If it's a big one that is really a serious incident, the legal team of the hospital might be involved, because it can go up to, looking into compensations and big sums of money going out. So it has to be sent out to the complainant within the time frame, the response. If that is not happening, a letter of apology and explanation need to be sent out to tell them this is not happening. We were thinking that according to our protocols, you should receive it in 20 days, but due to some delays, we are sorry, we're going to delay it for another 2 weeks or something. Sometimes after you respond, the parents are not satisfied with the response. Parents, carers, or whoever made the complaint is not satisfied with the response. That's absolutely fine. And actually, at the end of the letter of the response, there is always a line. If you are not happy with this response, please feel free to, you can raise it up to the ombudsman. And it's the same, it's ombudsman everywhere. It's ombudsman in Northern Ireland, it's ombudsman in Wales, Scotland, and in England. So it's the same one with different emails and different links of how to get to them. But that is a must thing that you have to put at the end of your response. If you're not happy with the response, feel free to send it up to the ombudsman. The ombudsman will not accept any um, complaint from a parent or a carer or whoever did the complaint, unless it has been responded to primarily by the trust of the hospital. So if the hospital has not yet said, yes or no about the complaint, the ombudsman will not look into it and will reject it automatically. Okay. Always do not forget to disseminate the departmental learning. There are some newsletters sent in some hospitals about learning from incidents. They just send it anonymously. They don't mention names. They don't mention departments, but they just say, when prescribing medicine that look alike and what is it what they say, the problem with the medication that look alike and sound alike, do this and that and that. And so they don't say that there was a mistake happened on ward 2 by Ayat who did the wrong medication. Yeah, they don't say that. They just put it broadly. Learning for individuals involved, if there was a registrar or another colleague, consultant, or someone else, and there were mistakes made, they need to reflect on it. If there was no mistake made, they need to reflect on it again. So if you are a trainee and you had a complaint against you, you must reflect on it regardless of the outcome of the complaint. Because that is someone has misinterpreted something you said, even if you were right. But then you have to go back and say, why did they complain against me? And then write that down in your portfolio. So that must be done. Some complaints and some incidents are big enough to trigger an audit or a QIP, and that can be done in every department. Some people will decide, okay, let's look into this. People are complaining about this. This is the second complaint we get during this month about waiting or about dirty cubicles. We need to look into housekeeping and what's happening there. So a QIP can be something that comes out of it. And how do you formulate all this when you talk to the assessor? So in the station, unfortunately, you only got 4 minutes to read a whole page of a complaint sent by a parent, which happened to me. So a page and a half, I think, or something like that, or a page about a complaint of a parent who was writing about details of the management of their child, and they expect you to read it in 4 minutes and respond to it in the 8 minutes after in the station. It's very tough and very stressful, I can tell you, especially if you haven't done this before. So I advise every ST7, ST8, go and sit with the governance team and sit with your nurse manager and all that, and ask them, how do you respond to complaints, and see how they do it. Look into their responses. That's something you're going to do once you finish training, and no one, will teach you. So what you will say about this is, you will read the complaint, and then you are talking to the assessor. Hi, have you read the scenario? Yes, I read the scenario. You can start talking about it now. And then he'll say, okay, I acknowledge that this is a complaint sent by a parent about a certain incident against different things. So the complaint I had was against few things, not just one thing, not all clinical, some non-clinical stuff as well. The first thing I said was, okay, I know that I have previously been involved in responding to complaints in my hospital because this was part of my training. And so I said, I know that there is a local protocol and guideline for responding to complaints, and that's the first thing I'm going to look into. I'm going to consult the governance team, and because I'm a new consultant and I have not done this before, I'm definitely going to ask the help of another colleague who has been there for me for a while, maybe the governance lead of the hospital, the governance lead of the department. There's always a colleague who is that, to help me at least navigate of how to do this. But my thinking about this is, before I can respond, I acknowledge this was a very stressful situation for parents, and that's why they made a complaint. But before responding, we need to investigate. To investigate this, I need to go back to the date of the incident. I need to look into the details of the notes of my colleagues, the nurses, look into the ANA, PAU, or AAU, whatever you call it in your hospital. And then I'm going to create a timeline. And then I'm going to go into looking into the cause of each of the problems raised by the complainant. And then I can produce the response. I'm aware there are timelines. I'm aware that there need to be a response before certain time. But if this investigation is taking longer than expected, then I'm going to tell the governance team to issue an apology and let the complainant know that this is going to be delayed a little bit. Then, after saying all this, you talk about the problem. So this should all take like a minute and a half or 2 minutes talking, and then you talk about the details of the problem itself that was mentioned in the complaint. You know, if it was a lumbar puncture that was unsuccessful, okay, did they tell them beforehand? Was who did the lumbar puncture? Was it supervised, not supervised? Who attended the lumbar? You know, all these things. If it was a dirty cubicle, then yes, absolutely apologize, and then the hospital will need to make changes to make sure that this doesn't happen again. If there was a wrong diagnosis, then that is something else. Why was there a wrong diagnosis? Now, you have to look into that depending on the clinical scenario they give you, and then decide what needs to happen. If there was a mistake, no hesitation, apologize, no hesitation, and then decide what happens. But again, no individual blaming, no mentioning of names. They will be learning for the whole department. They will be learning for people who were involved. Do not forget to mention at the end of the station that um, a complaint procedure is not just stressful for parents, it's also stressful for staff who are involved. And I'm going to make sure that the staff involved in those procedures and investigations are well supported by their departments and by the right people. This will be very important tick to give you, you know, an extra mark in the station. Always, these are the things, you know, we usually forget. Yeah, you focus on the problem and try to solve it and respond to the parent, but yeah, don't forget your colleagues who are involved. Reflection, departmental learning. These are the few things that we usually forget about. But again, this is a chat between you and another colleague. Do it with a smile. Do it at ease. There are no markings. You can easily get need development, which is not a problem at all. You know, just take it and go and do it, and then done, finished. So no stress. Um, I'll take questions now.
Thank you so much, Dr. Gowai, for sharing this is valuable insight into critical appraisal and complaint. It is very, very informative, and we learn a lot today. In the chat, there is no any question. Please feel free to unmute yourself if you have any question.
Sorry, it's just more of a general thing. So there is no like a framework of how to respond to the complaint. It's more of like trying just to explain that's how you are going through the process and what are the things that need to be involved, like that you're gonna reflect, you're gonna involve the government team, and like end of the things I will say about the ombudsman body.
Yeah, also the only thing they're expecting you to do is to say that you're going to refer to the hospital protocols and guidelines. And
Oh,
that's good enough because they're not expecting you to memorize that framework. Even if there is a framework, you are not expected. You are day one consultant. You have not done this in your life. Don't forget, in start assessment, you are day one consultant. So they know that you have not done this before. And that's why I started the answer by saying this is a stressful scenario. I have not dealt with complaints like this before. I have seen people dealing with complaints. And that's why I'm definitely, before responding, I'm going to ask the advice of another colleague in hospital who knows more about this. This is what you need to say first, and this will save your day. Um, but they're not expecting you yet to go into details of the framework and all that. You know, if you go to NHS, what's it called? NHS resolution. If you Google NHS resolution complaint response, you will get a document or two or something like that about they have a framework of how they expect people to respond to complaints and how they expect you to investigate complaints. There is a document about that that doesn't say more than the steps we mentioned today. But it's good to have a look at it. Sometimes it just organizes your thoughts. So it's, yeah, go and have a look at that, and it might help you organize your thoughts.
Sure. Thank you, honey. Just another question. It's more about like for the start, is it gonna be like all the station in one day, or is it? I haven't been on the first one, so I didn't know exactly how it.
Yeah, it's the same like the MRCPCH exam,
Oh,
clinical exam. It's all on the same day, not just the same day, the same sitting actually. You sit in your chair and you finish all the stations and then you just leave.
okay.
So yeah, it will be either morning or afternoon sessions, and it takes how long? 3 hours or something, or I don't know.
Yeah, it's like 4 hours. It is 12 station, 10 station. It is actual, and there is a
Yeah,
break.
including the 4 minutes in between and the breaks, and there is a longer station, I think, for prescribing. And so, yeah, it takes about 4 hours at least. So get prepared, with your water bottle and snacks around you, so you can just you know, you keep yourself euglycemic, not hyperglycemic.
There is a 20 minutes break between the station. Muhammad Asma mentioned in the chat.
Excellent. Yeah, because sitting for 4 hours is going to be a backbreaker.
Yeah. Any other question?
I'm happy to receive questions even after the session. Yeah, no problem. Just send it to the BSAPCH email or go to the website and fill the online form, and then we can respond to that. That's no problem at all.
Yes, and there is a feedback link. Put it on the chat, please. We would like to hear about this session. If you can complete it, you will receive the certificate for attendance. And if there is no any other question, I will just close the station, and I would like to thank you, Hani, again for the wonderful presentation on behalf of all everyone who attend today. And also, I would like to thank all the participants for your encouragement tonight. And the next session will be on January. I hope if you can register and you can put your question in advance, and then we can answer it. I had a look to all the question, and there is no any interesting question in this session, but we are happy to take any question further.
Good. I just want to mention last thing is that the procedure about dealing with the datics is not very different from dealing with a complaint. It's the same thing, same procedure. Again, you don't respond to a datix unless you investigate, and that's how it works. Again, you get the datixes that are relevant to your practice or relevant to your trainees or something like this, and then you go look into the notes, investigate, interview people, and then you respond to it. No difference at all. The only difference is that datexes are internal and complaints can be external, because a parent cannot do a datex, but they can do a complaint, but staff can do datexes.
Yeah, thank you so much, Hani. And a lot of thank you in the chat also.
No problem. Welcome. It seems stressful, to go into the start assessment. It's not easy. People say you don't need to prepare for it. That's rubbish. You need to prepare for it, because most of the stuff they expect you to talk on are not things that they actually teach you about. Yeah, the clinical stations are fine. You can deal with them. But these things about like building a business case, about like creating a new service in a hospital. No, this is something, unless you had it before, you're not going to be able to do it. Or responding to a complaint, responding to a difficult scenario, an ethical thing about end of life care. As a registrar, you're always protected. Someone else takes decisions for you. Now they expect you suddenly from between ST8 and a consultant is one day actually, and next day they expect you to do it. So, it's a stressful situation, but knowing that there is no failure It's very relaxing. Just relax. Even if you got 12 need development stations, absolutely fine. Go and do your PDPs and you will have your CCT still. Thank you.
Thank you so much. That's reassuring. Thank you, everyone.
Sorry, Hani, thank you so much for everything. I'm just asking, like, how long does it take for like a good preparation for the start from your point of view?
It's that's a difficult question because everyone is different, but I can tell you we did a group in our deanery and we used to see each other over Teams. Maybe I think we met maybe 7 6 7 times, and every one of these we discussed one big topic. So one session we discussed safeguarding, one session we discussed end of life care, one session we discussed, teaching, and then one session we discussed something like this, about critical appraisal. So we chose the topics that are tough. Every one of us will go and prepare about it. We'll come and present it to everyone else, and then we do practice sessions. But it wasn't that formal, it was just full of laughter and jokes, and it was nice because people brought in evidence. So, if you want to study about end of life care, for example, and ethical scenarios, you need to read about the RCPCH document about end of life care. If you don't read that, do not go into that station because that will give you all the answers. Again, if you want to answer a question about a difficult colleague or a trainee in difficulty, the RCPCH has got their own document about a trainee in difficulty. So if you don't read these documents and if you don't know they exist, how? And this is why the preparation is important because it just brings your mind to the documents and things and the resources that you were not aware that they exist at all. So that's the only thing I will say. Read the resources. You need one document about how to build a business case. You need one document about, ethical scenarios. You need a session like this about complaint, and then that's all. But clinical scenarios, you're not going to be reading about clinical because you do it every day. You deal with it. Safeguarding. And by the way, there will be a bit of safeguarding in every station you go into, and they expect you to pick on it. So, for example, air safeguarding is going to be in every station, but in a different way. And there will be one station that is big safeguarding, that's all safeguarding, but other stations will have a little bit of it here and there, and they see if you can pick on the subtle things or not. Um, so yeah, this is why working in a group is always good because you don't see something, someone else sees it and points it out and says, did you forget about that? Did you see that? Did you see that? It's good. You can have your pen and paper in front of you. You can write things down. You can do all that during the assessment. It's absolutely fine. So it's literally not an exam, as they keep saying.
Thank you.
Okay, thank you for everyone, and I'm going to leave you for that.
Thank you so much for everyone, and see you on the third session.
Thank you.
You are all welcome.
Thank you, Allah. Ayat. Is my voice well heard?
Yes, we can hear you very well now.
Okay. Thank you for the nice introduction. I barely recognize myself while you were talking about me. I can see from the attendees that we have a number of non-Arabic language speakers. So I'm going to restrict myself to English only. Okay, so a start is kind of the exit exam, of course, it's other specialties have exit exams. In pediatrics, we don't have an exit exam, and this is considered the equivalent to the exit exam, although it's not an exam, it's not a test, as they keep repeating and they keep saying it's an assessment, it's not an exam, there's no pass or fail, but there are recommendations and notes about your performance and indicators that they will be commenting on. They expect you to take the assessment at the level of day one consultant. And based on that, they will either, give you for every station, you will be assessed on a number of things. And for every station, you will be given either that you are performing above expectation or you are performing at the expected level, or there is a development is required, or there is serious concern. It's very, very, very unlikely that you will get a serious concern unless you do really something silly, or you have just not been during this training doing anything, but it's very, very unlikely for you to get a serious concern. I think only a handful colleagues got it, I think, previously. Less than a handful, actually. But it's very likely that you will get a number of stations as need development. That's absolutely fine as long as you can work on it. So, you can even get all the stations as need development. That does not mean anything. It will not stop you from having your CCT. It will just increase the amount of work that you need to do in order to get your outcome 6, which is completed training successfully. Because you'll have to work on these PDPs. Okay, so today I am going to talk about two things quickly. One is a critical appraisal, which by itself, we can be talking about it for like 3 hours at least, if we go into it deeply. And the other thing is, I'll touch a little bit on the complaint and the complaint procedure if you get one. Okay, let's move to the first session. Oops, first slide. Is it moving? Is it moving?
No, yes, it is moving.
The slides are moving.
Yeah, it is moving now.
Okay. Thanks. So the critical appraisal, yeah, exactly. When you are presented with a paper, it looks like that. Very complex picture of numbers and statistics and results and things that you need to make sense of each. We are very lucky now that you get sent the paper a week at least before the